I'm Robin Toohey, Senior Director, Support Groups of the International Myeloma Foundation, and it's my pleasure to welcome you to tonight's second quarter Living Well with Myeloma teleconference, What You Need to Know to Overcome Side Effects from Novel Therapies. This topic was selected as a follow-up to our first quarter Living Well call with our expert panel of doctors Duri, Abhinauer, and Raj Kumar answering your top concerns regarding treatment options and new drug approvals. If you missed that call, it's available for replay on the IMF's website at replay.myeloma.org. Tonight's program is part of the IMF's Living Well with Myeloma teleconference series, which is designed to cover all the important and most up-to-date information regarding myeloma to help you live well. I'd like to thank our sponsors for their support for tonight's call: Amgen, Bristol Myers Squibb, Celgene, Janssen, and Takeda Oncology. If you have not yet downloaded the slides for tonight's teleconference, please go to myeloma.org and click on the top bullet under New and Noteworthy, and you'll be able to access the slides there. You can also directly access the slides online at 2016sideeffects.myeloma.org. I would now like to introduce tonight's speakers. Dr. Beth Faiman received a Bachelor of Science in Nursing and Registered Nurse Certification, Master of Science in Nursing and Certification as an Adult Nurse Practitioner, and a PhD in Clinical Research and Nursing. Dr. Faiman holds an Advanced Oncology Nurse Certification and is currently employed as an Adult Nurse Practitioner in the Hematologic Oncology Department at Cleveland Clinic. Dr. Faiman is an active author, presenter, and educator on myeloma, is part of the IMF's Nurse Leadership Board, and is currently Editor-in-Chief of the Oncology Nurse and on the editorial board of ASH Clinical News, among many other notable books and articles relating to diagnosis and management of myeloma, pain, palliation, and cancer symptoms management. I'd also like to welcome Dr. Kevin Brigle, who received his bachelor's degree in biology, followed by a PhD in molecular microbiology from Virginia Tech. Following his completion of his dissertation, he was a postdoctoral fellow and later laboratory director in the Division of Hematology Oncology at Virginia Commonwealth University. Dr. Brigle is currently an oncology nurse practitioner in the Hematological Malignancies Clinic at the NCI-designated Massey Cancer Center in Virginia, and he's also a member of the IMF's Nurse Leadership Board. We're very pleased to have him present on our call this evening and to also field your questions at the end of this presentation. If you do have a question, please simply press *1 on your keypad at the end of our call. It's now my pleasure to turn this call over to Drs. Faiman and Brigle.
Thanks, Robin. This is Kevin Brigle. I'm leading off the talk here, and through the power of technology, Beth is sitting in Cleveland, and I'm in Richmond, Virginia, and I want to welcome everybody from across the United States and wherever else that you might be. And again, this is another presentation from the Nurse Leadership Board, which is organized by the International Myeloma Foundation. And so we'll go through these slides, and that's our pictures right up there on slide 1. So if we follow through from slide 1, we will now hit on to slide 2, which is titled Multiple Myeloma, a Cancer of the Plasma Cells. And so what are plasma cells? Plasma cells are the good guys in your body. They're the ones which produce the immunoglobulins or the antibodies. And so they rally to protect your body when foreign invasion comes, whether it be bacteria or viruses or things like that. And unfortunately, just like any cancer, a cell can go bad, and plasma cells are no exception. So plasma cells can acquire mutations, and just like any other cancer cell, they can become immortal and continue to grow out of control. And when they do so, they not only grow out of control, but they continue to produce that same antibody that they would have produced when they were normally functioning. And so they produce very large amounts of this, and this antibody is quite abnormal to begin with. And this is the monoclonal antibody that we talk about when we see patients. So how do we test for these abnormal antibodies? And these are probably tests that you're all familiar with. We check both the blood and the urine. We do the SPEP, or the serum protein electrophoresis. We do 24-hour urine proteins, and we also check for serum free light chains as well. And so all these tests can actually then identify these abnormal proteins that are put out by these abnormal or cancerous plasma cells. Moving on to slide number 3, entitled 2014 International Myeloma Active Criteria. And so how do we determine if someone has a multiple myeloma? Well, as we talked about on the first slide, we do a battery of tests, which include those tests, the SPEP and the UPEP. We check other tests in the blood as well. In addition to those, we do bone marrow biopsies. We do imaging studies, which are typically X-rays and sometimes MRIs and CT scans. And to be diagnosed then with multiple myeloma, as noted up here, you need a clonal bone marrow of at least 10% plasma cells in the bone marrow. And then any one of these defining criteria. On the left are the CRAB criteria, which we've used for many, many years, and that's an acronym for the calcium elevation, renal complications, anemia, and bone disease. And these are actually measures of what we call organ damage. Late in 2014, the International Myeloma Working Group also added what we call MDE, or myeloma-defining events. And these myeloma-defining events are actually early markers of myeloma disease. And so patients who have what we call a smoldering myeloma, we know that patients who have these characteristics, listed there as a clonal bone marrow greater than 60% plasma cells, a serum-free light chain ratio of greater than 100, or greater than 1 focal lesion on an MRI, those patients are what we consider high risk, and that they are more likely to progress from smoldering myeloma into active myeloma. So the point of these myeloma-defining events is to actually identify patients before they develop those CRAB criteria, or that organ damage, which is shown there on the left. Moving on to the next slide, you see a table here. The multiple myeloma is typically preceded by precancerous conditions, and the conditions over here you can see are listed on the left: the clonal plasma cells, the presence of myeloma-defining events, and then across the top are listed what we call the plasma cell disorders: the MGUS, or monoclonal gammopathy of undetermined significance, smoldering myeloma, and then the active multiple myeloma. If we look right across at the clonal plasma cells in the bone marrow, MGUS, or the monoclonal gammopathy, is usually fewer than 10% plasma cells. To get a diagnosis of multiple myeloma, you have to have at least 10% plasma cells, whether it be smoldering myeloma or active myeloma. And so the presence then of these myeloma-defining events, obviously with MGUS, not many plasma cells and nothing wrong, no CRAB criteria, no myeloma-defining events. Smoldering myeloma, you may have a lot of plasma cells, fewer than 60%, but again, no myeloma-defining events or those CRAB criteria. Patients with active myeloma do have those, and that's where we get a diagnosis. And so when we think about treatment, patients with MGUS, we simply observe those patients. Patients with active myeloma, we certainly are going to treat those. It's the patients in between with the smoldering myeloma. Those patients, typically we do observation, but we now have criteria for what we call high-risk multiple myeloma, and in clinical trials, some of those patients we're treating them as well. Likelihood of progression from MGUS is quite low, a little bit higher for smoldering myeloma. So dependent upon your risk factors and what precancerous type of condition you have depends upon how likely or how often we are going to observe you or bring you to the clinic and look at your myeloma numbers. It's the next slide. Symptoms may be from myeloma or treatment or both. So when patients are diagnosed, typically all these symptoms that you see on the left are going to be from the myeloma itself: the calcium elevation, renal dysfunction, the anemia, the bone pain, the fatigue, and things like that. And so hopefully as we get the disease under control, those symptoms are going to improve. And so we can do that again by treating the myeloma itself, or we can use palliative measures as well, pain medications, radiation, fluids, and things like that. As we get those myeloma symptoms under control, unfortunately we can cause other symptoms based upon our treatments. And so you can see over here on the right, the myelosuppression, the neuropathy, the diarrhea, and things like that. So our whole idea here is to hopefully not get rid of the disease symptoms and replace them with symptoms related to the treatment, but rather hopefully make the treatment quite manageable. And as you can see, those symptoms aren't mutually exclusive either. So we can have bone pain and other types of fatigue and things like that that are caused by the myeloma, but our treatments can also cause those things as well. So again, try to get rid of the symptoms of the myeloma and not just replace them with the treatment problems. So how do we decide on what treatment? And this is applicable whether we're talking about newly diagnosed patients or patients who are, let's say, relapsing, or even when we talk about maintenance therapy. And you can see the three circles up there on the right, and we talk about clinical experience and data from research. Obviously, your providers have that information, but that's not all that's involved in this as well. We also talk about the patient preference. There's a lot of things that go into making that decision, and the patient idea or how the patient is functioning and what they want is very important then as well. So when we think about, of course, right off clinical trial participation, we'd like to get all patients in clinical trial if indeed they're eligible, or if indeed we have one open. What are the current results of the clinical trials? They're going to be very important for patients to look at as well, and for us to look at. And what's the quality and the lifestyle that a patient has? If a patient lives a distance from the clinic, an oral regimen might be better than an IV regimen then as well. So what they're doing, if they're traveling a lot, again, oral might be better than an IV. So again, those are patient preferences. In terms of previous treatment, did they have treatment previously, and did they respond to that? How long was their response, and can we actually go right back to that treatment? In some cases we can. In other cases, maybe patients didn't tolerate that previous treatment, or they had side effects at the time, or maybe even still have lasting side effects that are going to make that previous treatment not a very good option at this point in time. But I would think that no matter what, no matter where you are, never ever shy away from consulting with a myeloma specialist. Most oncologists in the community, or wherever you might be, would welcome a second opinion. So certainly if you have that option, go for a second opinion. Very often you'll find that even what you're doing in the community is going to be right up the line of what can be done. So on the next slide, managing multiple myeloma, balancing act. Again, you can see those three circles up there, the clinical experience and the data from research and the patient preference. So we got that little balancing board there with a little triangle. And so when we think on the left there, so really these are things the provider thinks about: the disease characteristics, the efficacy of the regimens, what are the comorbid conditions of the patient, and how might the various treatments affect those comorbid conditions. On the right then, on that little balance board, is what patient preferences might be. So how's it administered? In other words, oral or IV or sub-Q. How long are you going to be in the chair? Some things are very, very quick injections. Others, we can spend a good 8 hours in the chair. So what's the patient preference there? What are the finances? What are their insurance? What are their support systems as well? So all these things are really, really important, and there's not one that's going to be the deciding factor. As you can see, we can pretty much tip the scales in one direction or another if we don't take everything into consideration. So the big point here is that we have to individualize every treatment at every step along the way, whether it's early diagnosis or relapse or even toward end of life, to make the treatment plan for every patient. Moving then into the next slide, slide number 8, says patients with myeloma are treated by a team. And absolutely, this is important, again, throughout the entire disease trajectory. You should have everybody behind you, everybody in your camp, from the oncologist to the advanced practice providers like Beth and myself, the nurses, and the nurses in the clinic are certainly going to be your probably your number one allies here. But we have the pharmacists, the orthopedists, physical therapists, for those of you who've gone through transplant or are thinking of going through transplant, that transplant team. And don't forget your primary care provider, too. We like to keep them involved as well. Financial counselors, social workers, and again, not just all these people right when you're diagnosed, but throughout the entire disease trajectory as long as you're being treated for your myeloma. All right, so the big one here, adherence, sticking to the planned treatment. So adherence means receiving the therapy as planned. And the treatment that we choose, some of these can be quite complicated. And we have treatment regimens where we take drugs once weekly. We have treatment plans where you take the drug for 21 days, then take 7 days off, and we have mixes of those then as well. We have certain regimens where you have to take 3 drugs during the day, 1 with food, 1 without food. So it can be quite complicated. And sometimes when patients aren't taking the drugs exactly as planned, in other words, not adhering exactly, it's not always the patient's fault, but sometimes it's ours that we don't quite explain things well enough. So what we do know, however, is that patients who actually take the therapy as planned and stay on therapy certainly have better outcomes. As you can see, that third line up there says the goal of therapy is to reduce minimal residual disease. In other words, no disease at all, if that's at all possible. And certainly patients who adhere to the treatment plan are going to do better there. There are certain patient factors, some of which we can fix and some that we can't. Some of those are listed there. Some of these is just the emotional response, denial of diagnosis. Some patients don't necessarily see the need for treatment, lack of understanding of the disease, and certainly that's something we can educate and certainly help with. Lack of confidence in your provider. Again, get a second opinion if you need to. Lack of access, forgetfulness, confusion due to pill burden. Again, these are all things, some we can fix and some that we can. There are obviously some health system factors, and anybody who's been through the health system at all knows that it can be quite a complicated system to negotiate, whether it's just insurance or these complex dosing regimens that we have, follow-up and discharge planning with your various providers, and just that relationship we have with you. So that probably the big one here that we're going to talk about tonight too is that inadequate management of side effects. So all of these drugs, while they're pretty well tolerated, can have some significant side effects. So really, really important that we talk about those with your nurse and with your provider. And that's here listed then on the next slide. So recognizing that basically as nurses and or patients and caregivers, we really all have a role in staying on treatment and adherence. And up there on the left, we talk about the nurse-provider roles. And again, the nurses are going to be probably your number one ally in the clinic. They're the ones you're going to talk to the most. And they're here, they're reinforcing the reason for the treatment plan, understanding that this is a chronic condition. And most patients who are starting therapy will stay on it for the rest of their lives. We usually don't get breaks anymore. And patients who receive therapy continuously usually do the best. They're the ones that are going to live the longest. And again, encourage a discussion of goals. What are your plans? What are your goals? Prevent, reduce side effects is a huge nursing function then as well. And they're the ones also who are probably going to be the ones who provide your calendars and also give you the most education in terms of side effects and things like that. From a patient caregiver role, ask questions, ask questions, ask questions. Definitely do that. Anything you do not understand, ask questions. The nurses are well-versed in answering those things, and what they can't answer, they will go to someone else and find out. Report those side effects. Report reasons that you don't like taking the medications. And again, we get treatment fatigue then as well, especially as patients continue taking treatment longer and longer with the myeloma. The really important box down there is at the bottom that says a pill that remains in the bottle or at the pharmacy is not able to kill myeloma cells. So if you have treatment side effects that unfortunately make you stop your treatment, there's not much we can do to help kill those myeloma cells. So even if we have to reduce doses or change treatment strategies, it's surely better than not getting any treatment at all. And with that little introduction, I think I'm going to pop this over now to Beth.
Thank you, Dr. Brigle, for giving us that wonderful overview. My favorite is that little box at the bottom that says a pill in the bottle cannot kill myeloma cells. And isn't that the truth? And so what we'll be doing in the next few slides is reviewing all of the wonderful treatment options we have. And some of this is going to be a little bit, it's going to mirror what the doctors had spoken about earlier on the teleconference call in the first quarter about the new therapies. But again, our goal is to kind of highlight what they did in a way and then provide some side effects. So right now we're on slide 11, and it shows that 2015 was an amazing year in expanding treatment options. 4 drugs were approved. We're going to go over them at length, and so I won't talk too much else about this slide, but it's just interesting. When I started taking care of patients 20 years ago, there were really no therapies available except for high-dose transplantation and melphalan and prednisone. Let's go to the next slide, slide number 12, that talks about the classes of drugs. And along that, with all the new drugs we have, we now are thinking of them as MIDES, thalidomide, lenalidomide, and pomalidomide. These are pills, or PO, per oral. They're pills that treat myeloma. The MIBs, the proteasome inhibitors, those are injectable and oral agents that are killing myeloma cells. And then the monoclonal antibodies, the daratumumab, elotuzumab, and some others. These drugs are typically paired with steroids, either prednisone or dexamethasone, which are very effective at treating the myeloma cells. They make a chemical that literally blocks the action of these abnormal cells. The chemical is called IL-6, and it just marries very well. So when we talk about the next drugs, let's try to think about them as MIDES, MIBs, or MABs. The next slide, 13, is what I think the most important information. There was so much important that came out of our ASH meeting, but these are just a few of the very important studies, 3 big ones for newly diagnosed people with multiple myeloma. The first trial used Revlimid pills. Again, that's an IMiD, or a MID, in combination with dexamethasone. And when patients got that treatment continuously without stopping, they did better than when you stopped or had a different therapy. So the first trial tells us that if you aren't getting a transplant and you, for whatever reason, want to just take pills to treat your myeloma, this could work quite well. So when Kevin talked about the different decision-making, maybe you only want to take 2 pills to control your disease, and many people can successfully control it, and this trial shows us you can do that. The SWOG trial, we call it the SWOG 777 trial. This study said that 3 drugs with Velcade, Revlimid, and dexamethasone were better than the 2-drug therapy RD. Now, while RD can be very good just as 2 drugs for some people, the addition of the 3rd drug really made a difference in some. The problem with adding Velcade up front is the peripheral neuropathy, but we know that careful attention to this side effect and intervening when people develop numbness and tingling in their fingers or feet can delay the worsening of the neuropathy, and you can get the benefit then of the 3 drugs. What we do know is that 3-drug combinations with drugs called chemotherapy, such as cyclophosphamide or Cytoxan or melphalan, aren't good in people that are elderly and maybe less fit. So when you're a newly diagnosed patient with myeloma, we know the IMiDs are good and the proteasome inhibitors are good, so the Velcades and the Revlimids, but we're still trying to find the best combination for myeloma, so therefore clinical trial participation is recommended. The next slide, slide 14, talks about the relapsing nature of multiple myeloma. Most of you on this call are aware that, as Kevin mentioned, there's this MGUS phase where there's an abnormal protein, and then all of a sudden something turns these abnormal cells on that turns it into an active phase. Through a series of remissions and relapses, ultimately, unfortunately, that cell just goes berserk. And then patients become refractory and relapse to nearly everything that's given. Myeloma is a clonal disorder, and those clones change over time. Maintenance or ongoing therapy can suppress those clones. So many patients with myeloma will be given maintenance therapy, whether it's just that continuous RD, like in that first trial, or after transplantation. The next slide talks about how do I know if the treatment is working or if I'm progressing? Well, the International Myeloma Working Group has put forth criteria that says whether or not you're responding by percentage points and whether or not you're progressing your disease. And I won't go into great detail on this slide because this can be quite complicated, but basically the take-home points is know your M protein. Protein can be in the blood, it can be in the urine, it can be elevated free light chains, or all of the above. So if you have a patient or if you're a caregiver for a patient with myeloma, know where the M protein is and make sure it's going down with treatment. We want to see that protein go down by at least 50%, which is a partial response, and then by 90% reduction is a very good partial response. Most of you are aware of the Black Swan Initiative and the MRD, or minimal residual disease zero that Dr. Dury is working really hard with the International Myeloma Working Group on. But not everybody will get rid of that protein, and that's okay. We always want to stay that protein down as long as possible, but disease progression will be when the proteins are increasing, and it's often by 25% and then repeated by 25%. Now, again, there's very specific criteria that the doctors and nurses use, but the take-home point is knowing your protein and keeping up on your myeloma labs. They're typically checked about every month in patients starting treatment. Now, the IMiDs, which are very commonly given at diagnosis, as I mentioned, are pills. The Revlimid is FDA approved at diagnosis and pomalidomide at relapse. For Pomalyst, we want to make sure that you take it 2 hours before or after a meal. And for both of the pills, we should not crush, chew, or open these capsules. An interesting point about Pomalyst is that smoking reduces exposure. So if somebody's smoking cigarettes, they may not be getting the full benefit of Pomalyst. It's important to make sure you're taking baby aspirin and watching out for blood clots by walking and remaining active. And your provider should be checking blood counts regularly. Now, the next slide is a lead-in slide 17 that says drugs used to treat early relapse. And we'll go right to slide number 18 that's titled MIBs, or proteasome inhibitors. Now, Velcade can be given up front, as we saw in the SWOG 777 study, and it often is, but Velcade is often given at relapse. If somebody stopped Velcade due to a side effect or a drug holiday or just because their planned treatment had ended, Velcade can be regiven, and patients will often respond as long as they were responding at the time that it was stopped, and often if it was greater than 6 months after treatment. So Velcade, which is given in a shot or an IV, is a very good option when the myeloma comes back or when patients are progressing. Kyprolis or carfilzomib is another MIB, and this is a drug that's given in an IV. It's approved for patients who have received at least one prior therapy in many different combinations, either in combination with Revlimid and dexamethasone pills or given by itself in a high dose, higher than it's usually given. This drug, in combination with the Kyprolis in combination with Revlimid and dexamethasone, has a very nice overall response rate of about 87.1% when it's given to patients who have relapsed after one therapy. So again, the MIBs, which are typically IV or shot under the skin, are good at relapse. Now, we've talked a lot about Velcade and neuropathy, and Kevin will be mentioning more about the side effect a little later on. But I wanted to highlight some important information about carfilzomib, and we call them patient pearls, and this is slide 19. We like to recommend starting carfilzomib because it's a twice-daily injection at the beginning of the week rather than the end of the week in case you have side effects. And those side effects can be mild shortness of breath. Sometimes you can get a little fever, low-grade fever, maybe about 100. And it's important to be able to contact your office and know who to contact if you develop these issues. We used to think carfilzomib didn't cause blood clots, but newer evidence is showing that, especially in higher doses, it can make patients at higher risk for blood clots. So remember strategies to prevent blood clots such as walking and staying well hydrated with water and taking an aspirin or another medication for blood clot prevention. We know Velcade and carfilzomib, again the MIBs, will put you at a higher risk for shingles. So taking valacyclovir or acyclovir pills can prevent shingles from even occurring. Be cautious for overhydration. Sometimes we give IV fluids a little bit too much sometimes. So if you're getting a lot of fluid, mention it to your nurse or your doctor. And oftentimes we will give you a water pill or some inhalers if needed. Now, slide 20 is titled Activism, an oral proteasome inhibitor. So this is another MIB. This is an oral agent that's given in combination, again, with Revlimid and dexamethasone. It's taken once weekly for 3 weeks out of the month. So this is approved for an early relapse. So if you've had one prior therapy, maybe haven't even relapsed, you can take this medication in combination with Revlimid and dexamethasone pills. Like the Pomalyst and the Revlimid, we should not crush or chew capsules, and it should be kept separate from your other medications. So the pharmacies will put it in a blister pack, and it's important to keep it in that blister pack. Take it on an empty stomach about an hour before or 2 hours after food, and it's better tolerated and better absorbed that way. Side effects such as low platelets, some stomach upset, and a mild peripheral neuropathy, again, not as bad as with Velcade, can occur. Some people notice swelling in the hands or legs, and again, it's important to report these side effects to your doctor or nurse team immediately so we can address them. This medicine is safe when given to people with kidney and liver problems. It's just important to start a lower dose than it's recommended. The next slide, 21, I really like this slide. It's a calendar. It's a sample calendar. We talked earlier on, Kevin mentioned about how adherence is so hard with all these pills. And this is a real nice picture and a piece of paper. I'll take a piece of paper and draw when you take your medications. Days 1, 8, and 15 is your Activism, for example. The Revlimid pills for 21 out of 25 days. And then dexamethasone is weekly. And this is really nice to keep handy, and I'll be showing other calendars throughout this presentation too. The next slide is starting to talk about the mAbs. Now these are the two new drugs. The first in class, what we call monoclonal antibodies, so their proteins are attacking and binding to certain cells in the body. This one, elotuzumab, is also approved if you've had 1 to 3 prior therapies, so earlier relapse. And it binds to what we call natural killer cells. We all have cells that are important in killing abnormal invaders, and it's important to our immunity. And so elotuzumab works with these cells and another SLAMF7 family, it's called. But anyhow, the antibody administration is the big deal here. So there is a temporary risk of infusion reaction, usually within the first few infusions, but they tend to be mild. So your nurse or doctor should go through a schedule of pre-medications with dexamethasone, acetaminophen, and some other medications. The drug is usually infused at a slow rate at the beginning, given weekly for 8 weeks, and then twice monthly. You take this medicine as long as it's working, so it's important to report any side effects of fatigue, or if you have signs of infection, because it's important to address your side effects so that you can stay on treatment longer. I mentioned infections is important, especially with these drugs, so wash your hands and avoid people with cold. And if you're on Revlimid, you should be watching out for blood clots, as we talked about with those IMiD class of drugs. The next slide that's titled elotuzumab dose and schedule is also a calendar. And it's just as I mentioned, we take the weekly for 8 weeks elotuzumab in the vein with dexamethasone and lenalidomide pills, and then you take it less often, twice a month, the elotuzumab. So the next slide is titled Treatment Options for Patients with 3 or more prior treatments, slide 24. We're going to go right to 25 and talk about daratumumab, also a new monoclonal antibody. This is approved for patients who've had 3 prior lines of therapy. This does have single agent activity, meaning it can work by itself and it's FDA approved by itself. New studies are showing that it's very effective in combination with other IMiD drugs and also other drugs as well. As with the other elotuzumab, there is a risk of an infusion reaction, so you will be instructed for pre-medication with dexamethasone, Tylenols, and other. The schedule is very similar to the elotuzumab. It's weekly for 8 weeks, then every other week, but this is different in that you can go to every 4 weeks. Because it can cause interference with blood tests, this CD38 molecule is weakly expressed on your red blood cells. So when you need a red blood cell transfusion, you should have a card in your wallet that tells you what blood type you are. In case you're in an emergency, we know we can transfuse that type of blood. This, like the elotuzumab and other therapies, are taken as long as it's working. Again, to suppress the cancerous cells so they don't grow and become abnormal. The next slide, 26, talks about Feradak. Feradak is a medication. It's called a pill called an HDAC inhibitor given 3 times a week. Some of the side effects of this medication is stomach upset and diarrhea. It also can cause heart problems. So if you've had problems with your heart, it's important to talk to your doctor or nurse. Much like the other medications that can cause shingles, especially because this is given in combination with Velcade typically. So you should be on shingles prevention and watch for neuropathy. The next slide that is another calendar slide, which I'll quickly skip over. It just shows the dosing schedule for panobinostat. This pill is only given 6 times per month in combination with bortezomib and dexamethasone. But again, it's going back to the adherence thing. Make sure that your nurse and your doctor are going through what's expected of you, because sometimes we can't be as clear as we'd like to. Now I have 2 more slides before I'd like to turn it back over to Kevin to talk more in detail about side effects. And I'm going to quickly go over these slides because these are just quick references for you. The different drugs, such as the IMiDs, the MIBs, the MIBs, and the MABs, can cause different side effects, so they're married together. It's important to be aware of the side effects that they cause so that we can jump in and intervene on these side effects. Slide 28 has the MIBs, the thalidomides, and the MIBs and the, I'm confusing myself now. How are you supposed to remember if I can't remember? The MIBs and the MIBs are on slide 28, and on slide 29 are the MABs and the HDAC inhibitor panobinostat. And with that, I'd like to turn it back over to Dr. Brigle to go in more depth with the side effect management. Thank you.
Thanks, Beth, and a nice overview of all those drugs. And as you pointed out on those last 2 slides, we've got a lot of new drugs, but unfortunately, we can have side effects to those drugs, and that's really our job, is to manage those side effects. Probably the biggest one, which we'll see on the slide number 30, the peripheral neuropathy, that's probably the one which gives healthcare providers the most challenge indeed. We talk about a couple of different types of neuropathy, being sensory neuropathy and motor neuropathy, and I think it's the sensory neuropathy, that numbness and tingling and things like that patients experience, which is really the most difficult one for us. And so the really important part about this is down in the box. Report symptoms early to your health care provider. Nerve damage from neuropathy can be permanent if unaddressed. So it's important to catch it early. We can always do dose reductions and things like that. So under prevention and management, we can adjust the chemotherapy dose. We can adjust the schedule so we can lessen the peripheral neuropathy and or prevent it from happening. We have other measures as well, which are a little more less involved in terms of the treatment, but massaging the feet with cocoa butter, keeping your skin dry. There are over-the-counter supplements, B6 and some B vitamins that people will try as well with some success. Some people use acupuncture then as well. I would caution, however, any over-the-counter supplements that you use, be sure and tell your healthcare provider that you're using those over-the-counter supplements as well. Some people get extreme cramping with this, so mustard, pickle juice, some tonic water, there are really no good prescription medications for cramping, but a lot of anecdotal type of things which are certainly worth trying, and certainly providing a safe environment in your house. Loose rugs, making sure your furnishings are properly placed, wearing shoes around the house, things like that, especially if you're having numb feet. If the symptoms worsen, again, we can change your treatments. We have other medications that we can prescribe, and they're listed right there. We can also prescribe pain medications because some people not only get just the numbness and the tingling, but can also get pain with that as well. And sometimes physical therapy can be very effective with peripheral neuropathy. Probably, though, on the next slide is the side effect which bothers patients the most, and those are the side effects of the steroid therapy. We use steroids, Decadron, prednisone, and those in almost all of our myeloma regimens, and we use them because steroids are very effective at killing myeloma cells. They usually do it, however, just in very high doses, and unfortunately, people can't tolerate those high doses very well. But again, they're going to be an important part of all the myeloma regimens. So with patients, we often have to get creative, the scheduling. Some patients take their Decadron in the morning or their steroid in the morning. Some people take it in the evening before they go to bed, such that it kind of hits its maximum, effectiveness, or when it is going to bother you most in terms of the mental challenges that come along with that toward the morning when you'd be getting up. So pick a day of the week that you want as well. Very often the day of the week doesn't matter so much with the steroids. We think about stomach protection. All of these steroids are going to cause increased acid in your stomach, so certainly take them with food, sometimes an over-the-counter prescription such as omeprazole or famotidine. Those things are needed to help prevent with the acid production. If that doesn't work, your healthcare provider can prescribe you something then as well. Steroids, again, are very good at killing myeloma cells. They do suppress the immune system as well, so they can leave you at risk for infection. So sometimes we'll put patient on different medications, such as antivirals or antifungals or things like that. And your nurses, I know, have talked to you about reporting fevers and some of those symptoms that Beth talked about then as well. Be sure if any of those things happen to report those to your healthcare provider. Weight gain can be an unfortunate problem, which everybody has to deal with. That's just an unfortunate problem with steroids. They have a little fat redistribution, and that can be a problem. And of course, increased blood glucose is something. The hyperglycemia, people who are diabetic can have very high blood sugars, and even a person without diabetes can have some high blood sugars as well. So very often we'll talk to the primary care providers to help us manage those blood sugar problems. In the next slide, diarrhea prevention and management. There are a lot of medications that can cause diarrhea. A lot of times we'll put patients on laxatives and acids, especially if you're taking pain medications. And so we have to make sure that if you lessen or stop those pain medications, that we get you off of those antacids and laxatives. There are a number of over-the-counter medications as well that patients are taking that can cause diarrhea. So again, the take-home message there is let us know all the medications you're taking, whether they be prescription and or over-the-counter medications. If you have diarrhea, absolutely increase the fluid intake. We don't want to have the risk of dehydration. If we get dehydrated, we start to have kidney problems then as well. So that's very important. Highly sugared beverages, carbonated beverages can add to diarrhea then as well. And we have a number of antidiarrheal medications. Some are listed there. Some are actually over the counter, such as Imodium and things like that. Others are more prescription, such as the Colecid or the Lamodal. And even some of the nice fiber binding agents, such as Metamucil, Citracel, Benefiber, are very good then as well. So we can have diarrhea, we can have that alternating with constipation, we can have issues that will change throughout the treatment trajectory depending upon what medications you get. And your nurses are very good at managing these problems with diarrhea and constipation. Next slide, and Beth alluded to this then as well, infection prevention, really crucial in myeloma patients because the myeloma cells actually do compromise your immune system in other ways, not only from just the disease itself, but also the treatment. So good personal hygiene is very important then as well. The environmental controls, wash your hands, avoid those sick people. Sometimes you can wear a mask then around when you're out in crowds then as well. If you have any of those signs of infection that we talked about previously, certainly report that to your provider. Sometimes, again, we'll put you on different medications. We talked about the antivirals for shingles prevention. Sometimes we'll put you on an antibiotic then as well. There are growth factors which can stimulate your immune system as well. We're usually careful to make sure that everybody gets their immunizations and those are up to date. We like everybody to have the 2 pneumonia vaccines that are out there. There's a 13 and a 23-valent one. And the seasonal flu vaccine as well, the inactivated one, which is the injection, not the nasal type. Very important that you do not get a live vaccine, and that would be something like the shingles vaccine, which is a live vaccine. And for patients who do have some ongoing problems, we can actually give what we call intravenous immunoglobulin as well, or IVIG, to help prevent recurrent infections. There are some disease-related effects, and that's on the next slide, slide 34, when we talk about the bone. Certainly a lot of people have problems at diagnosis with bone lesions, and all patients will get some imaging at diagnosis, whether it be x-rays or MRIs or PET scans. If people have symptoms, we'll again repeat those imaging studies dependent upon the types of symptoms that you have. In myeloma, again, 85% of patients are going to develop bone disease. And so when we develop the bone disease, not only is there a problem with pain, but that bone damage can lead to really high calcium levels as well. When patients get high calcium levels, that contributes to kidney impairment. So the bones are really important, not just for, again, structure, but if we have the problems with the bone, so it's pain, high calcium levels, and kidney impairment. So we'll talk about this in the next slide, but we like to put people on bone builders or those bisphosphonates to help prevent those bone lesions and those fractures from developing. With your nurses, of course, they they will certainly coordinate your bisphosphonate infusions with the treatment team. They'll talk to you all about the symptoms and things like that then as well. As a patient, certainly report new or worsening pain. Everybody has a little pain now and then, but pain that comes as new, feels like bony pain that doesn't go away. That is something you certainly need to report to your provider. Remain active. Exercise is great for strengthening your bones, and get regular dental exams as well. And why do we want to get regular dental exams? Well, that's kind of outlined here on the next slide when we talk about bone health and supportive care. All patients who are getting anti-myeloma therapy should also receive these bisphosphonates. Bisphosphonates being permethrinate or zoledronic acid. And these bisphosphonates, which we usually give once monthly, they bind to the bone and then they impair or kill the osteoclasts. Osteoclasts are cells that are in the hard bony part which actually break down bone. We have cells which build bone and break down bone, and the osteoclasts are the ones that break down the bone. And these bisphosphonates are very important then for inactivating those particular types of cells. The bisphosphonates do have some side effects. There's these acute phase reactions, which usually occur very early on in treatment, where you get fevers and chills, usually managed very nicely with Tylenol. They can cause some kidney damage over time, so it's important that we think about staying hydrated on the days that you're getting your bisphosphonate infusion. And we talk about dental health, very important here, because of an important problem which developed, which we found out early on when using these bisphosphonates, is that people can get osteonecrosis of the jaw, where parts of the jawbone actually die out, and this will prevent you from getting bisphosphonates in the future. So very important, again, good dental health to prevent that from happening. Other bone-related interventions, kyphoplasty, vertebroplasty, there's a picture of that there just directly on the right, where we can actually take a vertebral body which has a fracture and actually inflate a balloon in there and bring that back to normal size. Very good for taking care of pain. Radiation can be important as well. Then moving to the next slide, protecting bones and kidneys. Again, I'm going to not talk so much about the bones here, but the kidneys down here, avoid the use of non-steroidal anti-inflammatory drugs. We'll talk about this on the next slide. The big part about this slide is the blood clots shown on the right. So having myeloma or any cancer places you at a greater risk for blood clots. So stay hydrated is an important aspect. When we look at some of the side effects that Beth was talking about, some of those medications that we use, the anti-myeloma drugs, can increase your risk for blood clots. So anybody who is taking one of the IMiDs, again, Revlimid, pomalidomide, those types of things, or carfilzomib, one of the proteasome inhibitors, need to be taking a medicine to help prevent blood clots. Typically that's aspirin. If you have a history of a blood clot or any other risks, then we need to have something a little bit more significant in there, usually a Lovenox or a Coumadin or something like that. And there are symptoms, of course, of blood clots that are shown there. Report swelling, limb pain, shortness of breath, and things like that to your provider. Blood clots are a medical emergency, and those need to be reported. The next slide talks about kidney health. Kidneys are really important, obviously, for everything, cleaning out your blood, things like that. Unfortunately, patients with multiple myeloma can have kidney dysfunction just at diagnosis, because those high levels of proteins can impair kidney function. So active myeloma all by itself, the high calcium levels that can develop when people have bony disease, can impair kidney function then as well. Now, some patients come into their treatment already with some kidney damage related to hypertension and diabetes. And so taking care of your kidneys doesn't involve just treating the myeloma, but also taking care of those other health concerns that you may have. There are some symptoms, of course, you should let your provider know about, changes in urination, pain, things like that. We always tell patients to avoid certain medications. IV contrast is one of those, which can be very toxic to the kidneys. Avoid the NSAIDs, and those are the non-steroidals. Think about ibuprofen, Aleve, naproxen, and things like that. And stay hydrated. Drink plenty of fluids, whether it be water or Gatorade or whatever your choice may be, but plenty of fluids throughout the day. And how do we manage these kidney problems? Well, again, treat the underlying causes. So if it's related to the myeloma, treat the myeloma, and typically we can actually help repair some kidney damage with patients who have myeloma or have kidney disease related to their myeloma. And don't forget to take your blood pressure medications, your diabetes medications, and things like that as well. Those are really important to prevent the kidney damage. Then the next slide is really a summary to the key points which we've had so far on the first 37 slides here, and it's really important, though, the way that we treat and monitor myeloma continues to evolve. Length of therapy matters, so the longer you stay on treatment, the better the remission is going to be. Staying on, adhering to those medications is very, very important, and we want, as nurses and advanced practice nurses and everybody in your healthcare team, really wants you to remain on those medications. The do's there, open those lines of communication. There's nothing you really shouldn't be able to talk about to your healthcare provider. Share the goals, what your desires are for treatment, things that you want to do. And very important to write down side effects, any concerns that you have. The patients who really do the best are the ones who come in with a list of their concerns and their problems in as well. And as Beth pointed out, make sure your myeloma is regularly monitored. Know what your blood tests are. So your blood should be monitored if you're on active treatment, typically at least once a month. And so very important to get that done. And again, don't be afraid to ask questions. Always seek opinion from a myeloma specialist if you have any concerns whatsoever. And so with that summary, I'm going to shoot it back over to you, Beth, to wrap it up.
Thank you, Kevin. Such an informative talk. And I know we have several more slides here. These slides have been actually can be found and repurposed in a way from other presentations. So I would like to save time for calls, and I'm just going to just share my few key points about the slides that I'm not going to talk about, slides 39 to 44. Again, clinical trials are important. We don't move forward with always doing what we've always done. We had these 4 new drug approvals last year. Side effects are very manageable if we know. So open your communication with your healthcare team. Like Kevin said, the patients that do the best are the ones that come in with a list of prepared questions, and they take part in their own care. That's why I'm so thrilled that you're willing to listen to this teleconference today. Know that the International Myeloma Foundation is there for you. There are multiple support groups and resources for you. On slide number 42, I wanted to highlight that myeloma is a very individual disease. You'll talk to friends in your support group and colleagues, and your disease is going to be very different, though, from what the person sitting next to you is experiencing. It's very individualized. So make sure that you discuss your wishes and your needs and your wants and what's important to you with your healthcare team, and don't be afraid to get a second opinion. Slide 43 has some more IMF resources. Don't forget the info line, 800-452-CURE is there for you in U.S. and Canada, 9 a.m. to 4 p.m. Pacific. And lots more coming out of the Nurse Leadership Board from Dr. Brigle and I. I'd like to close there and say you have questions and we have answers was our last support group, but we really liked it so much that we left it here. Do we have time, Robin, for a few questions, or moderator?
Your first question comes from Betty.
Yeah, hi. I'd like it if you could talk a little bit about the side effects of fatigue, and other than walking, what other things you could do to minimize it.
Kevin, I think I can take this. So this is Beth Faiman again. We didn't mention fatigue. The area of fatigue research is only shows that exercise and walking, as you mentioned already, Betty, has been the most impactful, but not in myeloma patients. There has not been enough research. In my practice, I know that steroids can have horrible side effects, but there are some patients that benefit from low doses of prednisone, either every other day or every day in some cases, to give you a little lift, especially if you've been on steroids for so long. You can get what's called adrenal insufficiency. Your body is looking for that steroid that you might not have on hand. So discuss that possibility with your doctor or healthcare team. A low dose of steroids from here to there might be right for you depending on your health considerations. There are other medicines. There's one called Ritalin, which is given for ADHD, and I've prescribed it to some of my patients in my practice, which can kind of give you a little bit of a lift. Unfortunately, it can go the other way in some people and cause a little bit of anxiety and other symptoms. So it's important to have that discussion with your healthcare provider. And then finally, ruling out other causes of fatigue, such as thyroid problems. Maybe you're having problems with your heart. adjusting the doses of your medication. If your cancer's in remission, do we need to give you all those doses? So again, make sure your healthcare provider knows about your fatigue, and there are any of those other interventions and other things to look for we can recommend. Kevin, did I miss anything?
No, I think you covered it all. I think one of the other sources of fatigue that we'll commonly see in patients is anemia, and presents, of course, because we have a lot of bone marrow disease. So low red blood cells or low hemoglobin, and hopefully that improves as your myeloma gets under better control then as well.
Absolutely.
Thank you.
Thank you.
Do you have time for another question from the phone line?
Of course.
Yes, Lisa.
Okay. Your next question comes from Robert.
Hello.
Hi, Robert.
Yes, I've been on RD since 2009, but lately have been getting various infections of different sorts. And I'm concerned about shingles, and you mentioned that shingles prevention. Is this something that I should take routinely? Is it something you take once? Is it something when a shingle, event might be occurring? Can you explain that a little bit?
Kevin, would you like to try this one?
Yeah, I'll take that. Certainly, in patients with compromised immune systems are more likely to come down with infection, shingles being a really common one, especially with some of the medications, not so much with Revdex, but again, you've been on that a while, so that your immune system's going to be compromised. As you get older, your immune system's compromised, and older individuals typically come down with shingles more often, and that's why these patients, or the shingles vaccine is actually indicated for older individuals. So you're at risk for a couple of things, and so when we talk about using medicines for shingles prevention, we mentioned acyclovir and or valacyclovir, and yes, that is a daily medication, and typically you can take that forever. It's a very inexpensive medication for the most part. The acyclovir is just taken twice a day, and it's a preventive dose. It's not the actual treatment dose, but a preventive dose, and it can be very effective as a preventive dose.
Yes, that sounds good, Kevin. And I just wanted to make 2 points. The shingles vaccine, as Kevin mentioned, can be given to older individuals, but it's not recommended in patients with blood cancers because it is a live vaccine outside of a clinical trial. So you wouldn't get the shingles vaccine. Another thing about the recurrent infections you might be experiencing, we will often taper patients off the dexamethasone so that you kind of just stay on that maintenance Revlimid as long as you weren't on a clinical study that prohibits that. But if you're getting more and more infections, dexamethasone might be part of the culprit, and it might be worth discussing it with your healthcare provider whether that's right for you. Thank you, Robert.
Thank you.
Maybe one more question from the phone lines?
Last question.
It's from Kim.
Hi, my question has to do with, I know with the elotuzumab there is a oral portion of the dex and a IV portion of the dex. I have a couple questions. Why is it done in two parts like that? And do you think there's different side effects between the oral version and the IV version? And you also mentioned that the protocol for daratumumab is the same as it is for evo. So is the dex the same with that drug as well?
I'm happy to take this one. So that's a very insightful question. So the reason for the various dosing on the elotuzumab is because it's the 24 hours, 3 to 24 hours before you take the elotuzumab, it's recommended by the manufacturer that you take the dexamethasone to prevent a reaction. When you're given the IV, which is usually when you hit the infusion suite on the day of elotuzumab, it tends to be the IV 8 milligrams is a common dose. It might be different for you. And it's your bioavailability and your body recognizes the dex, whether pill or IV, is the same. In a lot of my patients, I will just have them, if they've been on ELO for a long time, take the pill form to speed up their treatments and decrease the chair time. As far as daratumumab, it's very similar. Again, the reason the manufacturer recommends one way versus the other is based on the clinical trials, and then that's what gets added into the package insert and the prescribing information. And again, it is pill dexamethasone the night before with the daratumumab in most cases and IV. Now again, the most common times you'll react to these drugs are within the first few infusions, within like the first 3 or 4. But afterwards, we're getting people in my practice off of some of these antihistamines, like such as the Benadryl can make you so sleepy, and the dexamethasone doses are greatly reduced as they're in remission longer. So I hope that answers your question. Kevin, do you have anything to add?
Not really. I would say with at least in your first infusions, as well with the daratumumab, we also it's I guess recommended by the manufacturer to take the steroid a couple of days later because you can get delayed infusion reactions then as well. But again, as Beth pointed out, those are usually just with the first infusions, and it gets much more better tolerated after that. And getting patients off the dex is probably a huge quality of life improvement.
Yeah, do you think the dex side effects are different between the oral and the IV version, or do you think the side effects are the same?
Wow, I think they're the same, but I'm only basing that on not on personal experience.
Yeah. So I agree. Your body recognizes the IV and the pill as the same, but when the nurse squirts the dexamethasone into the IV, maybe over a minute or 2, or drips it in a bag, sometimes people will feel differently in the chair. They might feel that rush a little bit quicker because it enters your bloodstream quicker, but overall the sleeplessness and some of the other mood swings can be a little bit different. But remember, everybody's an individual and will experience different reactions to different medications. So if you're not tolerating the pill or the IV, or if you want one versus the other, just talk to your healthcare provider, because really I say to the patient, what would you rather do? Would you rather have me put it in your IV so you don't have to remember to take it, or do you want to take it of your own accord? Maybe you like it at nighttime after a while, things like that.
Okay, thank you.
My pleasure.
Well, Beth and Kevin, those were fantastic tips that you've shared, and the few questions that we did have time for were really, really helpful and informational. And I want everyone to know that these slides are going to remain available. You can print them out. You can reference them online at your leisure. And also, we do record the calls. And later this week, the entire call with the audio with Kevin and Beth, as well as the slides, will be available so that you can listen again, because it was a lot of good information, and because the last few slides we went through rather quickly, and those were geared more for your reference post-call, so you can review those. I'd like to really thank Kevin and Beth for all the time they took in preparing these slides and going through them and helping us all to learn more and to live better lives with myeloma. And so just a few reminders. If you need a good reference with a wealth of information, it's always the IMF website at myeloma.org. And also, if you do have additional questions, the IMF info line has answers. So that number is 1-800-452-CURE, which is 2873. And Missy, Judy, and Paul are available to take your calls Monday through Thursday from 9 a.m. to 4 p.m. Pacific, and on Friday during the summer hours from 9 a.m. to 2 p.m. Pacific. So thanks once again to our wonderful presenters tonight, Beth Faiman and Kevin Brigle, and also to our sponsors, Amgen, Bristol-Myers Squibb, Celgene, Janssen, and Takeda Oncology. And most importantly, thanks to all of you for listening on this call, and I wish you well. Have a wonderful evening.